So some of the factors that have been considered important that you would want to think about is the patient displaying psychological issues about trust or feelings of lack of control or helplessness or feelings of vulnerability, feelings of dependency or shame. These are patterns we found from our research that the patients talked about their illness in the same way that they experienced the trauma earlier on. So this is something that breeds true into how they meet any new challenge. They may meet it in that way. There are medical disorders that are more commonly associated. This includes chronic pain, like CAPS, severe constipation and dyssynergia, like we've been hearing, sexual dysfunction, morbid obesity, alcohol and substance abuse, particularly narcotic bowel, unexplained vomiting, and multiple DGBI and functional somatic symptoms diagnoses. The more you hear about this, the more you have to consider this is relevant. It's well known that there are certain psychiatric disorders that have a higher prevalence of ACEs, somatic symptom disorder, dissociative disorders, especially multiple personality or DID, post-traumatic stress, panic, anxiety, depression, feeding and eating disorders, personality disorders, particularly cluster B, such as borderline, substance-related and addictive disorders, and factitious disorders. There are illness-related behaviors. Does the patient present with disproportionate disability? Are there multiple procedures and treatments going on? Is there high healthcare use? Are there difficulties with certain procedures? As gastroenterologists, we see this when we do rectal exams or endoscopy. So let me tell you, give you a brief case report